Hi, everybody. This is the recording for week 6 in quality management in healthcare. And we're going to talk about the tools that are used and that are so important to measure quality management and our process of quality management. So you can see that measurement is very important and is really the basis of successful CQI. Which is continuous quality improvement. Also, we talk about TQM. The two are interchangeable. And data is used to evaluate our current situation. So we've talked before about doing a value stream analysis where we actually collect data at each step of a process, whether it's putting together Big Macs at McDonald's or assembling cars for Toyota, or in our case, taking care of patients in the healthcare environment. Data is also used to analyze and improve the processes that we use and to track and monitor new processes. In our readings, we saw that there are two types of measurement in PDCA. We know that measurement in the plan do continuous is continuous, and that measurement and data collection methods and analysis are used continuously in the do, check, and act steps of PDCA, and that different tools are and can be used at different stages for the best data collection and analysis. And so we're going to talk a little bit about these tools in the lecture today. But first, we know that there's two types of variations, and that in the PDCA or quality management processes, we've learned from our previous readings that variation is considered the fat in the system, and that this fat needs to be reduced. We talked about unified practices, standardized care plans. These are all attempts at getting rid of the variation in our practices. So variation is the extent to which the process differs from the norm, from the standards that we've established. However, we've also learned and read that it exists in every process, especially when you're working with humans and human behavior. And in patient care, it will always exist due to the differences in our patients' needs. Not only are we humans that are caring for patients, but the patients are humans that are being cared for. So that increases the chance and the need for variation in the healthcare environment. We want to consider the two categories of variances that occur in our practices. The first one is called common cause variance, and it's considered to be random in nature. It is the type of inherent variance that's in every process, and it's systemic or internal variation. The second type of variation is called special source variations. Those are the ones that are externally caused. They attributed to a particular source, and they're non-random. So these types of variations could be things like the situation that's occurring on a unit at any one time. Maybe not enough staff is causing a variation in patient care. Attributed to a particular source, which in that case would be staffing ratios, and it's non-random. Whereas the common cause or internal types of variations are those things like nurses wanting to do it their way, or physicians deciding that they want to do it their way, and they're not following the standardized procedures, so that's causing a variance. The effects of variance in healthcare we've talked about before, and a good example from our textbook reading is that of the hospital that had 6 obstetricians, and several of them used the same IV solution for a delivery, a baby's delivery, and one decided that he wanted to use something different. So the nurses were kind of stuck between a rock and a hard place because they never knew which OB would be called in to do a delivery because they're on call and they rotate call. So the nurses decided that they needed to protect themselves and always be ready. So they started hanging both types of IVs. And so when the physician arrived, they then found out which IV solution was going to be used based upon whether it was the 5 that used the same type or the one that wanted something different. But you can imagine that if they did this for every delivery, that it caused a huge increase in the cost of those deliveries, and that it was a variation in the process and the procedure that was used for delivering babies. We've talked about variations and the effect also in other industries such as aviation, and this is the same situation that occurs. We've looked a lot at the Blue Angels and how they have to be trained, they have to be educated, they have to be retrained, they have to evaluate their practice, they have to communicate among each other, and this results in decreased variation. So just like in healthcare, the goal of any quality improvement process is to get things under control. And of course, the Blue Angels have to have assurance that every step that they take, every process they do when they fly those planes, that the process is under control, that it is standardized, and each one of those pilots in one of those Blue Angel planes is doing the same thing at the same time. So the goal of CQI, to have things more under control, decreases the variation in the process. And being under control is a process that has little variation or variation only under very predictable circumstances. So for instance, if you had a patient that you were administering a medication to, and you saw that that order for the medication counteracts the allergy band that the patient has on, you would immediately request a variation in that order. So if the doctor ordered penicillin and that patient is allergic to penicillin, then the nurse would take it upon herself, or the pharmacist, whoever picked up on that, would find out that they needed to call the doctor, remind the doctor that the patient is allergic to penicillin, and have that order rewritten. Because the predictable circumstance when you have a medication allergy is that the patient's going to react. And the patient knows that. That's why they've got that band on their wrist that says they're allergic. It's documented in the chart. And so someone has to, in that process of medication administration, there are several points of contact where allergies are supposed to be checked. So the goal is to keep it under control over the long term, recognizing, though, that we do have human nature and that we need to allow for variation, but only under very predictable circumstances in healthcare. So today we're going to talk about the tools for quality improvement. And there is a set of statistical methods used in process analysis that are common, standardized methods to collect data and validate data. And so these 8 are known as the primary tools for quality improvement, and they include flow charts, cause and effective diagrams, check sheets and lists, Pareto diagrams, histograms, run charts, regression analysis, and control charts. So even though these 8 are the commonly known and standardized data collection and monitoring tools, as the TQM process has been implemented, there's been variations on these and also additional ones, so that now we have anywhere up to 10 or 12 different types of tools. CQI is broken down into 4 stages, and the process stages and quality tools are really very well defined on page 99 of your textbook. It's an excellent chart that illustrates each CQI process stage and the appropriate tools for each stage. So we're just going to go through some of those right now. But as a review, stage 1 of the CQI is to describe the process and identify sources of variation. Stage 2 is to conduct in-depth analysis and to clarify knowledge and present the results. Stage 3 is to weigh alternatives and to make choices. And stage 4 is to measure improvements and monitor progress. So let's look at some of these tools. In stage 1, which is to describe the process and identify sources of variation, one of the tools that we use are flowcharts or diagrams. So we want to diagram this out to have a visual image. By diagramming, it helps to trace the steps of a process or steps that an object goes through. So in the McDonald's example, it is the steps that it takes to assemble a Big Mac according to the standards that McDonald's has established. In healthcare, there are many steps and processes to deliver care to a patient, whether it's the admission process, that the patient enters the hospital, sits with the admitting clerk, fills out the paperwork, then is escorted to the unit, and the nurses accept the patient and orient them to the room and how their patient care is going to take effect. So it just goes on and on. If it's a car assembly, then it's the process from the minute the first bolt starts to be looked at and the assembly of the car throughout the assembly line. So there's many, many processes, and flow charts are used all the time to try to document the process. And you can see how detailed they can be. That this, for instance, looks like it's looking at placing an order or how to route incoming phone calls. So the first step is that someone answers the phone and they asked, how can we help you? If the person says that they want to place an order, then it goes into finding out the name of the company that the person represents, and then they transfer it to the sales department, who then is going to have their own process chart of how to complete that sale. But for the person answering the phone, then that's the finish point for them because they've made a successful transfer. If they asked, how can we help you, and there's another request, then that goes off and there's a whole nother process flow chart for that next request from the caller. If it's a problem, then they ask, what is the problem? And then the person needs to either send it to shipping if it's a shipping problem, or to billing if it's a billing problem, or whatever other department might be involved. But if it's a problem with the product, then you can see they take the name of the company, they transfer to the help desk, and then, in fact, their part of this process is finished. But each one of these steps leads to another flow chart, to another process identification. Another type of tool that's used in this step 1 of CQI are called cause and effect diagrams. This is called a fishbone chart or an Ishikawa diagram. It was developed by a gentleman called Kaoru Ishikawa from the University of Tokyo way back in 1943 for use in the steelworks industry to interrelate multiple causes of process variation. So what he wanted to look at is that once the process was well defined, that they'd gone through and they knew each one of the steps, then the next step is to identify what are the causes of the variance. So this is most used when a team has already described the process and now they're ready to look at the variations in that process. So you can see that this was a process for deliveries and that they had identified that there are issues for incorrect deliveries, and the variances along their value stream they'd identified as communication, skill levels, transportation levels, and the actual procedures that were involved in delivering a product. So this is the Ishikawa or the fishbone diagram that can be a very good visual representation of the variances. Then the next step or stage in CQI is that of to perform an in-depth analysis to clarify knowledge and present the results. So you can see that oftentimes our process is seen as just chaos. Here obviously is a very intensive care, patient care room. But one of the things to help look at doing an in-depth analysis, as we well know, is the use of checklists. So we want to go from chaos to the use of a very well-defined checklist. This one happens to be for a lumbar puncture procedure. And you can see that it is well-defined, the different steps that need to be taken before and during a lumbar puncture. And it's done according to tips so that you've got indication. So you're supposed to check, if you're the nurse getting ready to do this lumbar puncture on a patient, you're supposed to check that there are certain indications for this procedure to be done. Then there's certain contraindications, and these are some of the predictable outcomes. If the patient is allergic or they refuse or they have increased abdominal pressure, any of these things that are under this area of contraindications needs to be checked. The patient needs to be asked, and if any of them occur, then more than likely the procedure won't be done, or at least they'll go back to the starting board to see if the patient's going to have a positive outcome. Then there's pre-procedure tips and a checklist or certain high priority boxes that need to be assessed for that. Then there's procedure tips. So there's certain things that the nurse and the physician have to do to set the patient up for a lumbar puncture, make sure that they're ready, and that the steps are followed for that lumbar puncture. And then there's also post-procedure things that need to be done. So at any one of these check marks, check boxes, if something is not done correctly, then that's a variance, and then the process team would look at why that variance is occurring and how it can be improved. So then you go back to the whole PDCA process. This is a very good example of a checklist that is used in the hospital for just one procedure. Another example or another tool is that of the Pareto diagram. I'm sure most of you have seen this. This is data that's been collected that then's put into a bar chart, and this particular one has problems that have been identified in the TQM process across the bottom, and then the frequency of those problems along the vertical axis, and it's done by priority. So the vertical bar chart is arranged from the longest on the left to the shortest, so meaning the most frequently occurred variants or problems to the least frequently occurred variants or problems on the right-hand side. And each bar represents the frequency of the specific cause of errors. So you can see in this one, it looks like there was some kind of a computer IT type of a process that they were looking at. And the highest priority or the highest problem area is that of unable to download, so whether it's a file or things that are being sent or from the internet. The biggest problem that this group of people were having was identified as an inability to download information. The next one is that they can't find the file in the system. And then the third highest priority is that it opens as a read-only. So you can see in this process improvement process, they've already looked at the different steps of the procedure, and they've identified the highest priority or the highest, most frequently occurring problems that are affecting the successful process. Stage 3 of the CQI process is to weigh alternatives and make choices. And the focus is on collecting data on the chosen causes and then selecting alternative ways of decreasing their frequency. So a regression analysis provides a way to look for unknown or underrated associations in a process. There's a good example of this in the book. Gardner and McLaughlin developed a regression model to forecast the utilization of perishable blood products in a hospital. So they were trying to look at whether blood products were being used appropriately, whether they were being used within the expiration date, because all blood products do have an expiration date. And the staff brought this problem to the attention of the quality management team because they thought that there was one physician that was overusing blood products. So they implemented a quality management or TQM process and put it through, the value stream analysis. They collected data on all the different physicians on their unit and when they used blood products and looked at patient priority, patient conditions, patient needs for use of those blood products. They also documented the expiration date of the blood products. And then they looked at a regression analysis to really look at if there was anything underrated or unknown in the process. If anything was coming up in the data that said, well, this physician required more use of blood products because of his maybe patient acuity, how sick his particular patients were, or patient diagnosis or whatever. But in fact, by doing this process, they found that their hypothesis that this physician was overusing blood products wasn't true at all. They found appropriate data, appropriate information to show that he was using the blood products according to the standardized process. So that's just another way that you might have an inkling or a suspicion about something that you want to investigate. You could put it through this same quality management process and determine if in fact your hypothesis is true. And then the last stage of CQI is to measure improvements and to monitor progress. And at this stage, one of the tools that we can use are control charts. Here again, I am assuming that you all have seen these types of charts, and they can be configured using simple statistics such as looking at the mean, the standard deviation, and the range of the data that you've collected. So you can see here that it's a series of dots and lines. You dot out your data, and then you can collect it with lines to be able to then visually determine what your high priorities are and what your low priorities are. So very similar to the barcode or the bar graphs that we saw earlier. But this instead uses dots and lines, and then you establish what your upper limit and what your lower limit is, and then you start to evaluate. You see that there's one dot above the upper specification limit. So that then tells this quality management team that that's their highest priority, and that's the one that they're going to look at more closely. So the end result of all of this, as we know, is that our goal is to make sure that the process is under control and shows the latest changes, but not necessarily the final goal, so that each step, each glitch in the process, so it's either the highest priority on the bar chart or the highest spike on the other kind of control charts, then that's the one that you're going to then look at the rest of the quality management process and try to determine where the variance is, what outcomes you need based upon that variance, but then you just start right on over again after you've got that one under control and go back to the second highest cause of variance, and then the third highest. So that's why total quality improvement is not a linear process, but it's a circular process. So under the plan, the team must return to the plan stage to look at areas of further improvement. They need to assess which measurement tools are most appropriate to the aspect of the CQI process that they're working on, and that the goal is the development of a CQI process that is sustainable. In other words, you want to make sure that as you're making changes based upon these variances of practice, that in fact you are continually going back and developing an evaluation plan. We talked about that a little bit in our group presentations, that it's important when you determine a quality improvement process for any variance that you've built into that the evaluation. Are you going to go back and evaluate it in a month? Are you going to go back and evaluate it every 6 months? And so that's part of the circular process of quality management. Some things, if they're of a high priority, you may want to go back and evaluate within a week, and then a month, and then 3 months and 6 months. Some things are less important, and so you may put them on an annual evaluation process. So another tool that we use in healthcare to monitor quality is evidence-based practice. Evidence-based medicine has really been around for a long time. It had its philosophical origins way back in the mid-19th century. So even at that time, physicians and providers were looking at the outcomes of patients. In other words, were they getting better? Even alternative medicine practices, Chinese medicine, all of those types of things we're really looking at, is the patient getting better? And if the patient died based upon one of their therapies, then obviously that was an outcome that they needed to go back. And even though they didn't call it quality management, they in fact were looking at a quality management process to determine why the patient died, what caused the patient to die, what maybe were the variances in practice or the patient needs that weren't being addressed that resulted in a very severe outcome, which of course is mortality. It's also defined, evidence-based practice is also defined as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patients. So let's look at the practice of evidence-based medicine. Really means that it's the integration of individual clinical expertise. In other words, the education and background and expertise of the provider, the physician, the nurse, the PA, the clinician, with the best available external clinical evidence from systemic research. So you can see here the physician has got his stethoscope connected directly to the computer. So that's a little bit bizarre. But in fact, what evidence-based medicine is combining both the physician's expertise and the clinical research that has been collected over thousands of years and now is available through the internet, through our computer systems. And so it's a lot more easier to really practice evidence-based medicine. So the definitions of evidence-based medicine, just to determine clinical expertise, means the proficiency and judgment that clinicians acquire through their education and experience. When we talk about the best available external clinical evidence, we're really talking about clinically relevant research, and that's why you see in some of your assignments that you're expected to find references from peer reference journals, because that means that's a higher level of research than just something that you might see in Cosmopolitan magazine or Self magazine, and that it's patient-centered research studies. So really in our industry in healthcare, we want to make sure that the clinical evidence is coming from the patients, that then we can measure the outcomes, we can look at the variances in patient care. It doesn't do us any good to collect evidence that is non-patient related, so that even though we see a lot of things that are done with animal lab testing, and the FDA's work with, research on animals, usually that's just the first step. Even in academic centers, animal research is really just the first step. And then they try to determine a safe clinical study, and then they have to make sure that they are able to apply that research to patients and then look at the outcomes of those patient data studies. And that's one of the complaints often, or one of the benefits, if you're on that side of the table, of the process to get drugs and new equipment through our FDA process, because there are many, many steps that have to be done, many, many safety factors when we do clinical research that have to be acquired. And so in this country, the research steps to get something approved, to get it out on the market, can take many, many years, sometimes up to 10 years and beyond, to get things approved through the FDA. But all of that is meant to keep it safe for when we are starting to use it on real patients and in real patient care environments. So one of the complaints about evidence-based medicine is that of, mostly from physicians, that it is considered cookbook medicine. In other words, some providers feel that it's more like a recipe for patient care versus allowing people to have their variances, to make their own decisions about how they want to approach patient care. But on the other side of the table, it's not a cookbook approach because it requires a bottom-up approach. In other words, it's starting from the grassroots providers and the patients. So the information for evidence-based practice is coming from patient care and patient care outcomes. So it's now evolving as an outcome of the quality management process that's going on throughout the country. It also integrates best external evidence with individual clinical expertise and patient's choice. So there still is the opportunity to have patient's choice when we're collecting research and to make decisions based upon both those internal variances and external variances. And it's also an approach that's based on external evidence that can never completely replace the individual clinical expertise of the care provider. We've talked about that human aspect of the healthcare environment. You've got humans on the provider side and humans on the patient side. So evidence-based practice is not so standardized that it completely replaces individual decision making. It's understood that the provider will always have their expertise, they'll always have patient diversity, and they always must recognize that this is important within our industry. And then the third tool for quality practice that we're going to spend a little bit of time on is the implementation of the use of checklists in the healthcare industry. And we've done some reading from Atul Gawande, or if you haven't been able to read his books, you have access to some of his presentations on YouTube. And he talks about why we need checklists in the healthcare industry. And he presents a couple of different issues, and the first is the fallibility of human memory and attention. In other words, he recognizes that we are human beings. We forget things. We have short attention spans at times. We have all of those different variances that are caused when a crisis occurred. In one of our examples, we talked about an auto accident and how there's so many things that affect three different witnesses will all see that auto accident from a different perception or from a different situation or from a different spot or location. So all of those things affect the fallibility of human memory and attention. He also recognizes that in healthcare, there's a lot of mundane, routine processes and things that occur. For instance, going back to that labor and delivery unit that we use the example of the IV solutions, that, you know, an L&D unit, all they do is birth babies, and there's babies being born every minute of every day, 24/7, 365 days a year. So for the nurses that work on that unit, the good news is they're experts at delivering babies and working with the physician to deliver the babies and take care of those babies post-delivery. However, on the other side of it, this becomes very routine, and it becomes easy to skip a step on the checklist. And that may be the very time that that variance causes problems. Gawande also recognizes that healthcare is a very complex environment. There isn't any one unit in the healthcare environment, in a hospital or in a clinic or in an ambulatory care center or in a senior nursing facility or a convalescent home. There's not any one unit that doesn't have a certain level of complexity, that the patients are there for a reason, they're sick, they need to be cared for, and every single one of those patients has differences in their specific needs. So healthcare in itself is a complex environment. Another reason that Gawande says that we need checklists is that people lull themselves into skipping steps, even when they remember them. We saw that in the example from Miriam Hospital. We've seen it in a couple examples in our readings, that there's a belief that certain steps may not always matter. So here you get back to the individual culture, background, beliefs, education of all of the providers of healthcare. And whatever the reason is that they may think, oh, I don't need to do this step on the checklist, or I don't need to do this step. And they continue to do that until there is a problem. And then that's when the variance causes a problem, hopefully not too severe, but in some aspects, as we saw, the wrong knee can be operated, the, um, the wrong limb can be amputated, the wrong medicine can be given. So there's all types of examples, up to 98,000 errors a year in the healthcare industry. And that's because people may not be following the right procedure um, for the situation that they're in. So let's look at checklists in healthcare. The purpose is that they remind the staff of the minimum necessary steps. So you can imagine, going back to that lumbar puncture procedure, if they had tried to document every single little thing that was being done to accomplish a lumbar puncture, that checklist might have been 10 pages long. So you have to look at the minimum necessary steps. And people think checklists are easy to put together, but they really aren't. They take a lot of time. You put the first draft together and then you test it out on the people that are supposed to be using it. Then you get that information, you revise the checklist, you add things, you delete things, you take their feedback into account. Then you put it out there again for another trial period. You get more feedback. Does it work? Is it too long? Is it too short? Did we forget something? Then you take it back through the process again. So it can take an inordinate amount of time to develop just one checklist because you want to make sure that the people that are going to be using the checklist, number one, have bought into it. And the best way to get that buy-in is for them to have input into the use of the checklist. So you might have to do that process on 2 or 3 different nursing shifts with 2 or 3 different staffing patterns just to have the first round of input into the draft of the checklist. They're also meant to instill discipline and to create a higher level of performance. So some of the checklists that we know we've already developed in healthcare is that of the vital signs documentation checklist. Patient care plans, we have standardized care plans now that try to get patient care, quote unquote, under control so that there is some consistency and some guidance for the nurses taking care of patients on their units. And we have medication documentation that documents specifically the time and the outcome of medications that are being given. So for instance, if a nurse is giving a narcotic and it's ordered every 4 hours, then there's a specific documentation page in the patient chart or on the computer that they not only go in and document the time that it was given, but they also document the outcome. So if it's a pain management narcotic that's being given, they have to document the level of pain on a scale of 1 to 10, or a happy face from frowning to smiling. Everybody has different ones, but the happy face is actually a very standardized way to document pain. So they document the pain level at the time that their narcotic is being given, and then they have to go back and document maybe 15 minutes later, maybe 30 minutes later, to make sure that that medication that's being given is having the outcome that is being hoped for, to show that the pain is being managed successfully. So all of that now has been put into some kind of a checklist or a documentation chart so that if there's a question about medication administration on a unit, there is data now that you can go back into these patients' charts and start to collect the data and analyze it to see then, using one of those tools that we talked about earlier, whether in fact the patient medication is successful, not only the administration of it, but the outcome as far as patient pain management goes. So we read about one of the first physicians who wanted to introduce the concept of using checklists for evidence-based practice. And so in 2001, a gentleman named Dr. Peter Pronovost at Johns Hopkins Hospital wanted to look at preventing central line infections. And central lines are put in patients all over the hospital, mostly in intensive care, but there are thousands and thousands of central lines that are put in on a daily basis across the country. And Dr. Pronovost already knew that central line infections was one of the negative outcomes for patients that were trying to get better in an intensive care situation. So they could be really working on all the different things that were going wrong with the patient or that the patient's condition required. But when they put in a central line, they didn't want to add another problem by having that central line get infected. So Dr. Provenost started a study. He wanted to develop a checklist. So on a simple sheet of paper, he plotted out the steps to take in order to avoid an infection with putting in a central line. So he determined that doctors are supposed to, 1, wash their hands with soap, 2, clean the patient's skin with an antiseptic, 3, put sterile drapes across the patient, over the entire patient, not just the area that the central line is going to go in. 4, they needed to wear a mask, a hat, a sterile gown, and gloves. And 5, they needed to put a sterile dressing over the insertion site once the line was in. So you can see that this is a check, check, check process at each one of those steps to make sure that it was done appropriately. Now, for most physicians, their reaction is, these steps are no-brainers. Of course we know how to put in a central line. We've been educated, we've been trained, and we've been taught how to do this for years. So it really seems silly, and that's the reaction that Dr. Provenos got, that it seems silly to do something that was so obvious. However, they observed the physicians in this particular intensive care unit for 1 month pre-checklist implementation and found out that in more than a third of the patients, they skipped at least one of these steps. And so he could then hypothesize that by not following a structured and specific procedure for central line insertion, that in fact they did have problems and that patients were getting infections. So after that small amount of data collection, for the next month, he persuaded hospital administration to allow the nurses to actually stop the doctor if they weren't following those 5 steps. And so this had to be approved through nursing administration and through hospital administration and had to be presented to the medical staff and say, we're actually going to ask the nurses to stop you. So there again, we've talked a lot about culture, and this was a major change of culture at the hospital and on this particular unit, to have the nurses become the checkers of the physician practice. So they collected data for another month, and they did find that the physicians were skipping a certain step or certain steps as each physician did his own thing in inserting a central line. So for a year afterwards, they got permission for the nurses to evaluate central line insertions in the ICU. And the results were so dramatic that Dr. Provenos didn't think that anybody was going to believe him. But they found that the 10-day line infection rate went from 11% to 0. So then, based upon this information, they put it back through the PDCA system and they followed the patients for 15 more months. And they found out by really monitoring practice and following this 5-step, very simple checklist, but making sure that each one of the steps was performed, that after 15 months, they only had 2 line infections. They calculated that in this one hospital at Johns Hopkins, the checklist had prevented 43 infections and 8 deaths from infections and saved over $2 million in cost. So now Dr. Provenost had some really didactic data that was proven over almost a 2-year period of time. And so they started to test the use of more checklists in Johns Hopkins ICU. So he proved that these checklists accomplished what checklists elsewhere have done. They helped with memory recall and clearly set out the minimum necessary steps in a process. So he worked hard at it, but he was dedicated to making sure that this one procedure, now you can imagine it took him 2 years to develop a checklist and use it successfully for all of the physicians in his ICU, to prevent central line infections. So once again, we've talked about the effort, the commitment, and the cost of total quality management. But if you can have results that it saves lives and saves over $2 million in cost to the institution, then that's a long-term return on investment. But his idea still was met with resistance, especially from his peers. Some physicians were offended with the concept that this was cookbook medicine, that he was giving them a recipe and specific instructions of how to insert a central line, that there was issues related to the cost of implementing, going through this quality management process and the cost involved in that. The physicians also felt that they were too busy to do more paperwork. So forget the paperwork. Just let me take care of the patient is what Dr. Provenos was up against. And they were afraid that he was looking for evidence that their work was being questioned. So they didn't want to have that second pair of eyes constantly watching them and seeing what they were doing. But you can see that over several years, many studies and the influence of other industries such as aviation and manufacturing has led to the successful development and use of checklists in our industry, in healthcare. And if you continue to read John Nance's books and Atul Gawande's books, you're going to find that there's more and more evidence that checklists are being used successfully. But as I mentioned, it's a long-term outcome. It takes months, sometimes years, to develop checklists that are appropriate for the process that is being looked at and being standardized. And they need several levels of involvement in order for people to buy in and to recognize that they can be useful in preventing medical errors or healthcare errors. And I'd like to end with a quote from Aristotle. So you can go back as far as Aristotle and see that quality was being looked at way back early in our history. And Aristotle says that men acquire a particular quality by constantly acting in a particular way. So what he's saying is that quality comes about by structure, consistency, the lack of variance, and to getting things and processes under control in a particular way means looking for that control in every process that we do in healthcare. So thank you very much. I hope you've enjoyed this, and we'll continue with our quality management activities in future weeks.